Okay. Thank you for organizing such a great meeting, and it's so nice to see each other in person. And I see it here, but I don't see it there, so I hope it will show up. But since all the talks before were talking about topics related to my discussion, so I can just say that I'll rest my case after hearing all those wonderful lectures discussing individual differences. But still, since it came up, maybe I'll start first with a few disclosures and just to go to the basics of the definition of personalized or individualized precision medicine, which applies to autism, of course, is that we would like to assess the risk, to diagnose, to prevent, and to tailor the therapy according to the unique characteristics of each individual. This is considered kind of a new concept in medicine. It's used for quite a few years in oncology, and it's in more and more areas of medicine. But like everything else, we can see that many things were discussed for a while. And when looking at autism spectrum and related to those individual differences, I would like to suggest that we would refer more to autism spectrum disorders, as you'd see further. But since nothing is really new under the sun, those differences and looking at the history of the patient, to look at what he's doing now and to try to prognose and tell the future, it's something that already Hippocrates described in his book. And more recently, Leo Kanner was discussing in his book that referred more to intellectual disability. It's been a very inappropriate term, but it was used then of being feeble-minded. But he discussed it as a group of heterogeneous disorders, and he referred to the puzzling riddle of heredity as being one of the factors of those individual differences. I'll try to get to the point by looking first at a few children and adolescents and tell their story. And I'll start with Maayan. Please don't take pictures of the children. I'm allowed to present it, but not to disseminate it. But Maayan was born after a normal pregnancy and delivery, but when I initially saw her at 8 months, she wasn't doing anything. She didn't even raise her head. She was not smiling. She didn't do anything, neither motor-wise or language or communication. She was very dysmorphic. Actually, at that age was more dysmorphic than you can see in this picture, when now she looks very, very cute. She underwent an evaluation, and by exome sequencing, it was revealed that she has a mutation in the ARID1B gene, which relates to the Coffin series syndrome. It's a syndrome that was considered initially a syndrome of dysmorphism, intellectual disability, global developmental delay, but it becomes more and more linked to autism spectrum, and more cases of autism are being revealed with the Coffin series, and this specific gene and other genes related to this syndrome, their function is related to chromatin binding, so we can kind of postulate how it can be linked to both autism and intellectual disability. But the initial diagnosis of Marianne was actually global developmental delay, quite severe, and that we thought is a predecessor of very severe intellectual disability. She underwent from the age of 8 months when I initially saw her very intensive interventions. And with her improvement in her motor function, it became more and more obvious that she has symptoms of autism spectrum. And subsequently, around age 3, she was diagnosed with autism. And already she had moderate global developmental delay, not so severe. And eventually, as you can see, she made more progress. Initially, she was using non-augmentative communication, but then she developed also verbal language, and she recently was, she still has autism diagnosis, but she's very high functioning in terms of her intellectual abilities, so her IQ, at least by measurement, changed from very low to normal range IQ. I'll shorten this case. It's another child with actually just extreme prematurity, no genetic risk factors, and his initial diagnosis also was high functioning autism. Subsequently, for a period of time, he didn't meet criteria, and then again at 9 years, he was diagnosed with high functioning autism and anxiety due to extreme prematurity, which we also showed in one of our studies that it's a risk factor that can increase 10 times more the risk for autism. And Yotam, he will be related to the last part of my talk. He was diagnosed with Fragile X in the period of time that it was not allowed to say more than intellectual disability. You couldn't say autism in a person who was diagnosed with intellectual disability due to Fragile X. We first see him when he joined one of the Fragile X studies, and then it was overt autism, and his IQ was pretty low, 49. And in spite of all that, he's functioning quite well, almost independent. He runs marathons, and he participated in more Fragile X drug studies. But he was very concerned not to miss work during his visits to our center. So as you can see, persons with ASD can be very, very different. And I really like this quote. I'm sure everybody is familiar with it. And those individual differences can pertain, as you saw, to genetic or other causes like prematurities. You heard this morning about twin studies that although you have a common diagnosis, there are individual differences. The trajectory can be very different. Some we diagnose early, some later on. We may see autistic regression, comorbidity differences, many studies on gender differences in autism, and of course on treatment response. So when starting to think about those individual differences, and we're trying to get deeper into understanding the mechanism and then to target treatments according to those differences. And by looking at all the different genes that are associated with autism, there are many now. There are almost 200 genes that are associated very strongly with autism, but also we are familiar with non-genetic causes, like I mentioned, prematurity, fetal alcohol, and other causes. But from getting from the origin or the causes, the is it possible to treat specifically or to get to treatment? And I'll give a few examples from the genetic and metabolic area, treatment opportunities from the Fragile X studies, and some non-specific treatment approach. When I first started to present this area of getting from individual differences to targeted treatment, I was quoting this quote, and now I see that it's so many years ago. It's from 2014, but I think it's still a novel thinking of improving disability or improving autism by specific treatment. And treatments to autism, I think about it like a bit similar to a traffic jam. Not always you treat the cause of the traffic jam. The traffic jam can happen, and sometimes you just need to go around it. Sometimes the route can be much, much longer and more expensive. So the way in approaching treatment can be either trying to circumvent the difficulties or to find specific pathways based on genetics. And even those specific pathways that sometimes are looking at a very rare gene may sometimes be important and cause a common response that may relate to other genes that have similar function. Just to demonstrate it in those disorders that I showed before, all the white-colored areas are disorders where there is some research, some clinical research that tries to find a specific treatment that relates to the genetic disorder. And one example are the creatine deficiency syndromes in which we may approach it by trying to correct the lack of creatine. I showed here how we can find it. We can either find it the metabolites in urine or by MR spectroscopy. MR spectroscopy is a technique where we can see metabolites in the brain in specific areas. This peak of creatine when you have this syndrome is just lacking. It's you don't see it at all. You see the choline and the NAA, and this is an important finding because some of the creatine deficiency syndromes can be at least partially corrected by just adding creatine to the diet. Another common cause of inherited ASD and intellectual disability I discussed before, so I'm sure you can guess it readily. It's Fragile X syndrome, but not only Fragile X syndrome, also the premutation carrier. Those identical twins both have autism and Fragile X, but their mother, who has intellectual problems that are in the normal range. She has some learning disability and some anxiety. She was also found to have more than 200 repeats of CGG in the FMR1 gene. And just to explain in maybe 2 sentences how the elucidation of the pathway of and the function of FMR1 brought us to more understanding of treatments that may work. When you look at the normal function of FMRP, when you see the normal amount of repeats of CGG and normal amount of messenger RNA, the function of the FMRP, of the protein, is to regulate the amount of intracellular general proteins. So it regulates many proteins that are related to autism eventually and to brain connectivity. On the other hand, on this balance, you have another receptor. It's actually a group of receptors, mGluR5, that those proteins are actually upregulating the amount of cellular proteins. We have the FMR1 downregulating and the mGluR5 upregulating. So one of the strongest theories that brought to quite a few drug development was that in Fragile X, when you don't have the FMRP regulation and you have regulation of mGluR1 and more protein production in the cell, if we try to stop the mGluR5 by blocking those receptors, then we can decrease and kind of imitate the function of FMRP. So one of the mechanisms of genetic treatments, it's not sometimes substituting the missing protein or trying to change the genetic coding. Sometimes there is some other pathway that can be chosen. So many drugs were developed on this pathway of arresting the mGluR5 function, but also some drug development that was aimed to regulate other pathways related to Fragile X. And I'll tell you soon the results of all those studies. But another approach is going around the specifics of the genetic disorder. And we tried to treat by a treatment that we suppose that may influence the neurotransmitter acetylcholine, and by seeing similarities between autism and Alzheimer, we tried in a randomized study a drug that came from Alzheimer, is used in Alzheimer, called donepezil, that stops the function of acetylcholine esterase. So we have more acetylcholine, but also we added the choline as a substrate, postulating that children with autism may have a lot of food selectivity and maybe they have upfront less choline. And we actually found a significant language improvement in the group of children, but the emphasis was on the younger group, on the the effect was much better. If you want to look more on papers related to specific responses and specific etiologies, this is a journal that has 14 papers. It came out as ebook just yesterday. Some of the colleagues and friends here participated, Professor Gozes and Aviva, and sorry, I should call you Professor, okay, Professor Mimouni. And in these papers, you can see many responses of the treatments that can, of course, be related to the age that those treatments are started. And now more and more studies are being approved for younger children, which was a big issue in drug studies before. Of course, related to the diagnosis, to the severity at diagnosis. All the Fragile X studies initially started with the more severe individuals with Fragile X, and it was more difficult to measure. Of course, gender differences, and now there is more awareness of including girls in all those studies, because always we see more patients with autism that are males. Of course, we should look at the comorbidity and environmental influences. We just mentioned that the cover of this journal is my painting, so I was very proud of it, more than writing the papers in the journal. But going back to the Fragile X studies, that's a list. I don't expect you to read it, but there are many, many studies so far on different mechanisms trying or aiming to improve function in Fragile X patients. Our paper that was published recently was actually an open label and not a double blind, because that was one of the issues with those studies. But of course, the value of the improvement that we showed with this drug, Gabaxol, it's a bit debatable since we didn't have a placebo arm. But the main issue that brought us that we need to design different studies is that what happened with most of those initial studies, that there was a huge placebo response of about 40%. And in many ways that it was tried to overcome it again and again, the drug could not prove benefit above this huge placebo response. So this response kind of failed many, many drugs. But on the other hand, in the public and the patients, they were very, very happy with those studies. I was involved with 4 of those studies, and as I showed you with Yotam, patients are coming back even though the first or the second study did not succeed. And the reason is that all those studies gave so much hope. And if you think about it, it's all those patients improved by 40%. It doesn't matter to them if they improved because of the drug or they improved because of the placebo. So they were very happy with getting involved, and we are very grateful for their support. And yes, last question, last sentence. I have to finish by just mentioning that the behavior and educational interventions so far do much better than all the studies that I showed up front, and it was shown scientifically. And I will leave you with a hypothetical question of whether to treat or not to treat all those persons that kind of show themselves of supposing having autism. But what I'm saying that if they have the luxury to ask this question, then maybe those are not our patients that we need to treat. So thank you, and sorry about keeping you from lunch. Thank you.